University of South Florida in Tampa. Please note this session is being recorded. Thank you for joining us for this regional session of our Global Health Conversation series. I'm Lynette Menezes, and I oversee global programs for USF Health, which consists of the Colleges of Medicine, Nursing, Public Health, and Pharmacy. On behalf of USF Health International and the Global Virus Network, I want to warmly welcome each of you, especially our colleagues from Dakar, from all of Senegal and West Africa. The COVID-19 pandemic has continued to dominate the news, our daily lives, and the field of global health. But around the world, communities have been mercilessly suffering the devastating effects of so many other debilitating diseases daily, pushing them further into unimaginable poverty. One such group of diseases are the neglected tropical diseases, or NTDs, that unfortunately have been further ignored. NTDs affect over 1 billion people in 149 countries, with the global burden estimated at 16.5 million dailies in 2019. Although elimination and possibly eradication by interrupting transmission is an achievable goal, with several of these parasitic diseases, we have failed at eradicating a single parasitic disease. The issues are more complex than we might have thought and require us to rethink our current approaches and develop new frameworks to tackling these endemic diseases. NTDs lack the funding essential to develop new frameworks and for research to test these interventions. Overall, the world came together to beat COVID-19 much faster than it has for any other disease. The US government contributed $1.3 billion in funding for clinical trials and other research to develop the Moderna vaccine, but a mere $100 million in funding for NTDs research. So clearly, we can step up if we have the political will and commitment. Today, our speakers will discuss some of the successes and challenges in tackling these endemic, neglected infectious diseases and the need to reframe the issues in achieving their control and eradication. Before I begin to introduce our distinguished speakers, I just want to inform all our attendees that at the end of the presentation, we will leave some time for questions. Please type in your questions in the chat box, and the speakers will answer as much as they can. So with this, I'm absolutely delighted to introduce our distinguished speakers today, Dr. Amadou SALL and Dr. Edwin Michael. Dr. Amadou SALL is the CEO of Institut Pasteur de Dakar in Senegal, and the chairman of the Pasteur International Network of 33 institutions, as well as the director of the WHO Collaborating Center for Arboviruses and Viral Hemorrhagic Fever. He has been the past chairman of the Global Outbreak Alert and Response Network at the WHO and a member of the Coalition for Epidemic Preparedness and Innovation Scientific Advisory Board. Dr. SALL is a virologist by profession with a PhD in public health. He is world-renowned for his expertise in epidemic response and control, more specifically for arboviruses and viral hemorrhagic fevers, such as Ebola, Zika, and yellow fever, among other high-consequence pathogens. Dr. SALL is a member of several expert committees for WHO, the Special Program for Research and Training in Tropical Diseases, Strategic Advisory Group of Experts on Immunization, Strategic and Technical Advisory Group for Infectious Hazards, and the World Organization for Animal Health. He's currently the co-chair of the COVID-19 Laboratory Technical Working Group for the Africa Center for Disease Control and a member of the Africa CDC's Africa Task Force for Coronavirus Steering Committee, as well as the Senegalese Committee for COVID-19. He has been providing invaluable leadership in the COVID-19 response in Senegal and other African regions. Our second speaker today is Dr. Edwin Michael. Dr. Michael is a professor at the University of South Florida Center for Global Health Infectious Disease Research in Tampa. He's an epidemiologist who studies the spread and control of global infectious diseases. The overriding objective of Dr. Michael's research is to address questions regarding the population ecology, epidemiology, dynamics, and control of tropical vector-borne and zoonotic diseases, including lymphatic filariasis, onchocerciasis, schistosomiasis, leishmaniasis, Chagas disease, dengue and malaria, enteric diseases, and more recently, epidemic diseases such as COVID-19. A common theme running across these research programs is a primary focus on the development and implementation of novel analytical and computational approaches, which provide a deeper understanding of the determinants, pathways, and dynamics of disease transmission in endemic communities, and using the insights gained from these for identifying and analyzing sustainable approaches to disease control. Dr. Michael is a member of the Scientific Working Group for Lymphatic Filariasis for WHO and a member of the Scientific Advisory Committee for Integrated Tropical Diseases Control for Tanzania, and has been a consultant advisor for several countries, including India, Portugal, and the Regional Program Review Group for elimination of filariasis, and also for onchocerciasis elimination in Uganda. Currently, he leads the development of the CIRCAS COVID-19 modeling portal for supporting population-level response and hospital surge planning to contain the pandemic at the county level in Tampa Bay. With his timely modeling and predictions, his work and leadership has been vital to the Tampa Bay community when planning and tackling the various waves of the COVID-19 pandemic. With that, I will invite Dr. SALL to begin his presentation.
Thank you very much, Lynette. It's a really great pleasure for me to be with you today. And I really want to thank the organizer for giving me this opportunity to come and talk with you. Thanks very much for the very generous introductions. I don't know whether you can see my screen now. So I am going today to talk about how we should tackle neglected tropical disease in Africa by using surveillance and local manufacturing of rapid diagnostic tests and using dengue as a model. I think the topic of our conversation today is how do we integrate the control with the socio-economic development. And I think that dengue is a real good model for that. And that's why I picked dengue to give this presentation. Why dengue? Obviously, we're talking about a neglected tropical disease. One more also important aspect is dengue is a vector-borne disease. By being vector-borne disease, it is typically in a position where we will have some vector being involved, very well influenced by the environment, and also impacting human disease, where we have really a typical one else approach, which is not only important now, but which is also going to be the standard when it comes actually to tackle disease. Because obviously right now, we are facing a situation where when it comes to health, it's about talking about human, animal, and environment. The other reason why I am interested about talking about dengue in Africa is really that dengue is an important public health problem at the global level. But in Africa, dengue has been in a very unique situation where for years it was really a very, very neglected problem with very limited impact, particularly in Senegal. But this pattern is changing drastically in the sense that now, if you look at it, dengue is more and more present, not just epidemic from time to time. For years, people believed that African was genetically resistant. But now we realize that it's getting endemic and we have more and more epidemic happening. So the pattern of the dengue and the impact is growing with more and more dengue hemorrhagic fever having and a much higher morbidity. In Senegal, it's now become endemic, and every year we have several epidemics in urban and in rural contexts, while in the past, dengue was mostly a rural problem. Now, one important aspect in relationship with what we're talking today, which is the socio-economic development, is urbanization. If you look at Africa, I mean, over the last 3 decades, we have many mega cities that happen in link with economic development. And even in some rural area where people have some increase in terms of socio-economic level, we have urbanization happening. And this urbanization in the context of dengue has 2 major effects. Number one, we have the vectors of dengue actually colonizing more the domestic habitat and then impacting more the human health. But at the same time, it also has a second very important aspect, which is very much driven by the climate, which is a bit changing in some urban contexts due to the fact that we have many anthropogenic effects that are impacting the way that the environment is behaving. Now, the first example I'm going to be taking when talking to dengue is the system we established in Senegal, which is called Syndromic Surveillance Sentinels in Senegal. And just for some of you not familiar with that system, this is the map of Senegal, where all these dots of different colors are representing some sentinel site belonging to the Ministry of Health, where with Pasteur Institute, we are actually working across different climate, which is in different colors, climate zone. And where in each of those sites on a daily basis, we collect information of patients coming at those centers through some digital applications. This information about mostly the symptoms they have are going through some sort of database and collected on a daily basis. And at the same time, every week, several of those patients have their samples sent to Pasteur in Dakar. So through the samples and the tests that are being done and the information collected, we end up having a diagnostic and some symptom. And by doing that, we can follow different sort of syndrome, whether we talk about respiratory, arbovirus, meningoencephalitis, or jaundice. And dengue is among what we call arbovirus actually syndrome. Once we have this information about a syndrome and a diagnostic, then it is moving into some interactive web platform, become a bulletin, and is circulating around the different stakeholders working with the Ministry of Health. The reason why I'm describing this is that by having this system in place where you put together digital surveillance with actually a good lab capacities, you build a system where now we can detect any epidemic of dengue within less than 7 days, which is the time that we have the sample arriving to the lab and being able to do detections. The other important aspect of that is that if you look at actually this picture, what it shows is one of those sentinel sites on a daily basis, the report we have in terms of number of fevers and things can be followed in a way that over time, you can build up some baselines, and from time to time, you would see that you may have a number of cases of fever or syndrome that are much higher than the average, what you would see, and going beyond the threshold. And that's where you detect those epidemic. And through that process, we could on a regular basis detect dengue. And this is, for instance, the syndrome arbovirus, and most of the time dengue. When this peak is reached, what happens is we deploy usually a mobile lab to go into that area, collect sample, do the testing locally, and through the connectivity that exists to the lab, we just send the information to a digital platform that you can get access through a mobile phone very simply. And by having these capacities to do the surveillance for dengue, what is happening is that the information is transferred to some digital platform where you can have a real-time follow-up of daily evolution of the epidemic, the sex ratios, the different symptoms, and a mapping of vectors and a mapping of people. The reason why I'm bringing this into dengue is by doing that, you detect earlier the epidemic and you can control it much quicker. Now, when it comes to controlling dengue, there is usually vector control that is unfortunately not working very well, but usually making sure that people get isolated very quickly and avoid infecting more people and try to handle the environment in a way that would help actually preventing further infection to happen. If you look at this map here, you may have different colors for the different vectors, and this is mapped at the household level. What it means that in each household, through this system, you can measure some index of risk and see where there is a possibility that this epidemic may explode or this epidemic may go down. When it's red, it means that the index is very high and may promote epidemic, or when it is actually green, you know that you are lower than the risk of having an explosion happening. And in the absence of large diffusion of dengue vaccine, because it's not spread at all in Africa, this is a way where quickly you can have some vector control measure happening at the household level in preventing explosion of epidemics. Now, one of the things I want really to clarify here is as soon as we have this peak, we can go and get dengue tested. And when dengue is tested, you clearly can detect dengue, one of the serotype, and through the investigation, control the outbreak. And you can have, we have several examples of that. I just picked this, where you have all these syndromic surveillance happening, meaning that each of these syndromes is of different colors, whether it's respiratory or arbovirus or febrile. And you could see clearly that this one is definitely dengue. And when you pick the sample from people belonging to this peak, you can detect it very quickly, whether it's dengue 1 and dengue 3, and through the investigation control once again. So this is a very efficient system by which we're handling dengue now for years in Senegal, and helping in absence of large vaccination and limited actually vector control to help controlling this. And the reason why this is important is now dengue is mostly in the cities, and making sure we detect early to avoid the spread is very important. That's how, so making sure that you train people on how to make sure that they clean all the different recipient and container that have larvae, they can actually prevent those epidemics. So even though people live in cities where they have gardens, it's very typical to see in Africa where you have dengue epidemic, mostly the wealthy people are the ones that got dengue because they have garden where you can have larvae in the flower pots and mostly in the garden. So this is very much important, and understanding that those different containers need to be treated to avoid having an expansion in the context where wealthy people would be in much better position to be infected than poor people. Now, I just want to switch to the second example I wanted to give to this presentation, is where you need actually to come with a solution of manufacturing and building a social enterprise to make sure that you can control this dengue. And I'm going to be relating to an initiative that we call Diatropics, that Institut Pasteur of Dakar, together with FIND, with Fondation Mérieux and IRD, have put together this initiative where the idea is to say, if you want diagnostic to be accessible, let's make sure that we can make it, get people trained, and have us build an economic model that's going to make this sustainable in terms of impact to promote diagnostics. And to that, just showing why, on which this model is based, is really, if you look at all the impact that has on GDP of neglected tropical disease in general, you have a quite large and significant impact, as you can see on this map shown by World Bank, and Africa particularly being affected by that. But not only you have the economic impact, but you have a social impact because people are affected in their social life with that. And also you may have an health impact because people can be sick and die out of it. The main purpose of this initiative is really to say, okay, we're going to be manufacturing diagnostics that are not available, but are not satisfactory, available but not satisfactory, or available and not affordable. So by doing this approach, what happened is that we could build a financial model where through membership that all the partners belonging to the program are providing and the people that are willing to support, we develop a way to mutualize really the costs that are labor costs, operating costs, and facility management, leading to the condition where the test is only costing the price of the cost of goods to members and people actually that are having that test happening and that are having access to that test. So it's a kind of test that used to cost $5, $10 now can be manufactured locally, can be because of non-for-profit manufacturer less than $1 and be available for people within cities to detect dengue earlier. And because we have these capacities, because we have this possibility, this makes dengue something that people detect very quickly now. And obviously this experience has been used for other diseases like COVID. And this has been quite well in the media about the $1 test that we did at the very early beginning of this epidemic. So just to show very quickly the process, how it works on these preparing things, where you have a quality control, a formulation, and treatment. This is very simple operations, but done at the high level standard, where you have an ISO certified by world-renowned, stakeholder like a British standard institution, where all this process would lead to a local manufacturing, creating job, bringing innovation, and helping to control some of this disease. Now, we end up doing, in collaboration with one of our partners called Hemorrhagic, a dengue test, which was detecting not only the antigen, but also the IgM and IgG, which are both needed actually to be able to detect epidemic at the very early stage of infection, or do some follow-up to make sure that people are protected or are actually being exposed to dengue. And as you can see, the level of sensitivity and specificity you would see for this disease has been in the lab very good, around 100% of specificity. When we talk about the antigen, for the antibodies, it's a little bit lower, but the sensitivity is reasonably good. And when we do it in the field, it works quite well. And by doing this, we tend to actually put dengue testing anywhere where you do not have lab. And that's why it's critically important by having this capacity to build this company, this social enterprise. We have been able actually to not only create jobs and improve the social economic standard of the people working on that, but also helping the disease in urban context, but also in rural area. Now, I just want to conclude by saying a couple of different things that to me are important. Number one, the NTDs are really of major importance in Africa when we talk to impact, whether we talk about dengue or rabies or different NTDs, they are all very impactful, very limited capacity when it comes to prevention in terms of vaccine, but also quite difficult sometimes to diagnose. And in absence of vaccine, really the surveillance as the one we were trying to show and the diagnostic are really one of the main tools. And this is particularly important in area where you have demography and urbanization, because this is definitely linked to the increase of socioeconomic standard that's happening in several African countries and African cities. We have more and more happening. And in this regard, I believe also bringing this local manufacturing and social entrepreneurship as a way to control better is really a way to look forward, because it not only helps to control something that is known, but also it gives the capacity to focus on diseases that are really strictly of interest for Africa, but that are not really of great importance for the markets. And that's why I think this is also a model for the future. I will stop there and we'll be happy to answer any sort of question. Thank you.
Jesse?
Yes, Dr. Michael, go ahead.
Yeah, go ahead, right? Yeah, can you see this?
Yes, sir.
Okay. All right, everybody. Good morning, and thank you, Dr. SALL, for that presentation. I'm going to talk about, in relation to the topic that we are discussing today. And this is looking at the nature of, of parasitic disease transmission, and then what does that say about, how do we intervene to bring about sustainable and successful control? So that's what I'm going to focus on in the next 20 minutes. I'm going to start by asking a major question, right? And that is eradication or sustained control of the major parasitic neglected infectious diseases a simple, tame problem? And tame, I mean it in a very technical way. And that means that, essentially that both the problem and solutions are well known. And that is, if those are well known, and if we define that a problem is tame, then we can simply rely on biomedical approaches. And we can actually decouple it from the more social drivers of disease. Now, is that what is applicable to the control of the major parasitic diseases? Or do the control of the major parasitic diseases represent a complex, persistent, or even messy societal problem? And that would require new modes of governance. We can't simply rely on biomedical tools alone, because we have to couple biomedical tools with social drivers, that underpin the transmission of disease. So that is the question that we have to ask ourselves. So is, parasitic diseases, are they tame, or are they, do they constitute a complex socio-ecological system? And I'm going to start by looking at one of the, one of the targets that WHO always brings up, and that is, some thresholds. They will say for lymphatic filariasis, onchocerciasis, they've come out with some eradication thresholds. These are the thresholds that control programs have to meet. This could be prevalence, a minimal prevalence level below which the system will go and become extinct. And here I'm showing, is that a simple target? Or is the target, is that particular threshold very complicated? And if you look at many of these neglected tropical diseases, and I'm focusing here on lymphatic filariasis, LF, and onchocerciasis, these are macroparasitic diseases. They're worm infections, but transmitted by vectors, flies or mosquitoes. And they've got many interacting components. And for mathematicians, as soon as you have many interacting components, and many of these components interact in a very nonlinear manner, immediately flags will rise that this is a very complex system. And they will have emergence properties. And let me show you what I mean by emergence property. And this is a simulation that we have done. Y-axis is the infection levels in the human population. And on the x-axis, you'll see the mosquito biting rate, right? So I am increasing infection on the y-axis, and I'm increasing the biting rate or the vector abundance on the x-axis. And I want to see whether there's emergence property in the system. Oops. So let me run this. You'll see the biting rate is increasing. There's a lot, I'm seeding the new infected people in the system as well. Nothing happens until you hit a biting rate. Then the system will jump into existence. This is an example of a very complex system which has emergence properties. Already this is telling us that the systems are complex. And then these are some theoretical work, right? Can we predict those eradication thresholds? And the answer is yes, if you have a mathematical model, and that's why mathematical models are important. And here we did some theoretical exercises. This is a complex diagram. All I want to say is the solid lines represent endemic states, right? Infection prevalences can occur in the population. You will see, as I showed you in the simulation, below a particular biting rate, the system cannot exist. Even if infected people come, there's not enough vectors or mosquitoes or flies to transmit the system, and the system will be going down to zero. It's a zero attractor. But beyond the biting rate, which is known as the threshold biting rate, the system will suddenly emerge. It can emerge into a positive state with the solid lines, or it could also still be zero, and that is separated by this prevalence, which are these dashed lines. These are unstable prevalence. This is an example of a bistable system. Already complexity is coming into play, right? So the system can exist as a zero state or an endemic state, depending on how much infection is there in the population, how much mosquitoes are there in the population. I just want to focus on this area here. This is a maximal threshold values for eradication. Now, if you increase aggregation, if you go into any of the communities, infection is not uniformly distributed among members of a community. This is highly clustered. Now, if you increase the clustering from 1 to 3, the level, the maximum biting threshold for emergence of the disease will decrease. If you increase immunity in the population from 1 to 3, that will also decrease the threshold, the breakpoints, right? And then if you decrease the worm fecundity from 1 to 2, that will also decrease the thresholds. So immediately you're showing that this particular threshold values are going to depend on how much how infection is distributed in the population, how much immunity is there in the population, and both of these are actually social factors. And then the ecology, the worm fecundity rates. So immediately it's telling you that local conditions are going to be important. And so there won't be one uniform value for the threshold. This is another example of those thresholds. Once again, the solid line is endemic state, and then the dashed lines are the state that can divide the system into the zero state and the endemic state. And this is for Leishmania. And this is a very complicated disease, right? It's got many reservoir hosts and then the vectors have got preference for biting a particular reservoir host or the human host. And then the different hosts that the flies bite, these are sandflies, they also have different host competencies, in transmission. Now, this is showing that, remember I said this is a maximal threshold values. Look at the threshold values. They will vary in different, for different biting rates according to whether the vectors are preferring biting for different multiple hosts and differential reservoir host competence for transmitting infections. So already, you're seeing that, for example, in Leishmania, they can transmit infections into cows, goats, and humans as well. So livestock, and that is varying between communities. So therefore, the thresholds will also vary between communities. And then the sandflies will have different biting preferences, and that depends on the density of the livestock, density of humans. All that is varying between communities, and that will cause a variation in the biting, in the thresholds. So we have seen the threshold itself is very complex. Then the other thing that we notice for many of the parasitic diseases is this ubiquitous, spatial heterogeneities. And here I'm showing for Tanzania and Uganda over here, and that's Tanzania again. And this is lymphatic filariasis. The darker the pixels, the higher the prevalence value. The infection prevalence value. So a lot of infection around the coast, Lake Victoria, and then, it's variable across the rest of Tanzania. This is malaria. Once again, mostly seen around the lakes, coastal, and then less so in the middle part of the country. This is onchocerciasis, looking at nodal prevalence. Once again, you can see the higher values are clustered in different parts of Uganda. So this is a feature of parasitic diseases. Now, the question is, the key question is, are this simply noise, or are they fundamental driver or complexity? One way to look at it is to estimate the thresholds, the eradication thresholds. Now, WHO has set for lymphatic filariasis a universal target, 1% MF threshold that the MDA programs need to meet in order to eradicate the disease. But look at the actual threshold value, and let's just focus on at MF breakpoints at TBR, which is a threshold biting rate. These are the maximal thresholds that I pointed out before. Look at the values. They are much lower. There are two places where it is 1%, but other places are much lower. So highly variable, lower than the WHO set threshold. And the most important thing is these are villages, individual villages. They are highly variable between individual villages. And that is because of the spatial heterogeneities that I showed you on the map. So immediately it's telling you this is a complex system. And WHO and any other control programs always set this global value. So this will not work for those areas where the threshold is actually much lower than 1%. It'll work in areas where the threshold is about 1%, but not so in other other areas. And the impact of that is seen in the control programs, right? This is a number of years, and let's just focus on MDA here. These are different villages, and I'm looking at a 95% eradication threshold value. How many years will we take if suppose you implement a mass drug administration at 80% coverage? How many years will it take to reach the threshold value that the models have estimated, right? And this is a 95% elimination threshold. For Penang, it's 11 years. For Yawatong, it's 20 years. For Nanaha, it's 9 years. So it's highly variable, the number of years you'll reach those thresholds. Look at what WHO recommends. As usual, a universal single recommendation, 4 to 6 years of MDA should be applied universally across all these sites, endemic sites. And this is saying that that cannot work because the threshold values are highly variable, and therefore the number of years that you need to implement to eradicate the disease will also vary between sites. Then the other feature of complexity, and this is always the case, systems are not, parasitic systems do not occur in isolation. They are always co-endemicities. And this is looking at lymphatic filariasis and malaria endemicity and the impact that control of one will have on the other. Because if you look at malaria and LF in Africa, most, they can be transmitted by Anopheles mosquitoes, which are the common mosquitoes that can transmit both malaria and LF. Here I'm showing the simulations here for a particular setting, looking at MDA, mass drug administration. This is no MDA, you have the prevalence, stable. But if you bring in different coverages of MDA, you will, the initial baseline infection levels will be dropping until you reach the elimination threshold. And this is for lymphatic filariasis. You've got rid of infection in a setting where there's both infection, filariasis and malaria transmitting. And you've got rid of lymphatic filariasis, but see what happens to malaria. This is, malaria in the presence of lymphatic filariasis. And as you get rid of lymphatic filariasis, malaria transmission will increase. And this is a new equilibrium. So it's gone from 19 to 23, or nearly 24%. And that is because, as you get rid of lymphatic filariasis, the larvae of lymphatic filariasis that goes into the mosquitoes will actually kill the mosquitoes. Now you've got rid of lymphatic filariasis, so mosquitoes are surviving more and they're transmitting malaria more. And malaria is a much more dangerous disease than lymphatic filariasis because it also kills. So, these are the unintended consequences of targeting one disease and ignoring the other. And the other thing, the complexity that you can see is if you go into a particular village, you'll see a highly clustered transmission. And you'll see in these are households, and the circles are the level of infected people, right? So that, so if you look at this cluster, there's a cluster of high infection in the middle of the village, and then high infection in the northwest part of the village. Okay, and then if you start looking deeper, you'll see that the richer people will have lower infection levels, poorer people will have higher infection levels. This is once again for lymphatic filariasis. This is some of the work that we've been doing in Papua New Guinea and in Tanzania. And if you start looking at this distribution of infection between rich and poor, that is reflected by, like I said, remember I said infection is never uniform in a population. Most people will have zero infection. Some people will have light infection, but some people will carry most of the infection. And if you start dissecting who are these people, these are mostly the poorer part, the poorer segments of the population. The richer people have lighter infection or no infection. So here we're seeing a connection between the social structure of a population and then how it contributes to the distribution of infection in a community. This distribution is very important because it tells you whether there is a threshold, a positive threshold or not. High K means infection is more uniformly distributed. And if you look at them, the transmission rate for infection to establish will be much higher. If there's a lot of over-dispersion, which are related to the social structures, then the transmission rate for infection to emerge is much lower. That makes it much more difficult to eradicate the disease. So this shows the connection between sociology and disease ecology. And here we're looking at another factor of complexity. Many of the diseases have very long eradication tails. This is once again lymphatic filariasis. This is India. We had MDA. It'll reduce infection very quickly, but over a long time, infection will still be persistent. And this is in Polynesia. Infection was reduced by MDA and vector control very quickly, but then it lingered for a long period of time, up to about 30 years. This shows a long eradication phase, and this is a feature of very complex systems. The systems will try and persist, as you bring in interventions for a long period of time. So it's very hard to get rid of this infection. So we went into Tanzania and looked at schistosomiasis, right? And they had 3 MDA rounds, mass drug administration, but still there was persistent schistosomiasis transmission. And we looked at the factors of the persistence. And the main factors were gender, which is a social construct, how gender behavior is included, is involved in transmission. Wealth status was the other factor, and wash indicators. All of this are social indicators of disease. And those were the factors which are keeping schistosomiasis persistent, showing the importance of socio-ecology, in driving persistence of the disease. So then we come to the last segment of my talk, and that is asking the key question. If disease is a complex system and the socio-ecology involved, how do we govern or resolve this kind of complex systems? And here I'm showing, the current control programs, the WHO directed control programs. These are the global control programs for entities. You have a high level of people. This is what is known as epistemic networks at the top level. These are very close problem solving and framing systems. WHO, donors, NGOs. These are mostly people educated in the same kind of institutions. They come together, mostly clinicians, right? And then they make decisions about control. And of course, being clinicians, they normally go for biomedical approaches because they think sociology, can be dealt with. We can decouple, the tools from sociology. And that information, all, the control programs are developed here, passed on to the states. States might have some impact on modifying the control program, but mostly the control programs are done at the high levels, very top down. The states then, the knowledge flows also from one direction normally, from top to bottom, very little bottom to top. And then state is simply used to deliver prescriptive top-down solutions, right? The intervention programs are designed here. The state simply delivers that. And then, and then the state also then simply very little engagement with the community at large, right? And our community perspective. And does not consider the complexity of nonlinear, like I just showed you all the complexities. So it's a top-down command and control approach normally in the control programs. And that will not allow us to experiment, right? And to find solutions, social solutions. So how do we move towards an integrated socio-ecological control framework and not simply rely on drugs, on vaccines, and other things, which are all biomedical? This is looking at social economic development in Africa and transmission. This is malaria. And this is only African countries. look at social, as economic development occurs at the national level, GDP, malaria just collapses, but we also need to look at geography as well. This is looking at NTDs, burden, in Dalis. And this is in the temperate region, and this is a subtropical region and the tropical region. Most of the burden is in the tropical regions. But if you look at the per capita GDP, these are also the poorer countries. So geography and sociology, also plays a role. And that's why we need to start reframing, how do we control this in this area where you got poorer communities, but geography is also driving disease transmission. So socio-ecological. So how do we build a socio-ecological kind of system? The other work we did was, building this social vulnerability index for soil transmitted helminths in Africa. Vulnerability is a function of exposure. These are all ecological factors. Susceptibility of communities. These are occupation, nutritional status, age, etc., etc. And then you got lack of resiliency in the community. This composes a lack of capacity to anticipate, lack of capacity to cope. Household wealth, education, wash behaviors, and then you have the health system and governance to cope, right? So we go and find all these indicators, and then we develop this map for community, vulnerability to soil transmitted helminths. Let's simply look at this map here. And the darker areas mean these are much more vulnerable communities to soil transmitted helminths. And if you start decomposing the factors, there's one factor from ecology, NDVI, vegetation, which plays a role, but most of the other factors are lack of capacity to anticipate and susceptibility. These are social factors. So most of the factors driving vulnerability are social factors. So how do we build a social ecological intervention? Is an example. This is a nice example from Japan. So after the war ended, this is the prevalence of soil transmitted helminths, right? This curve here. So, and this is the gross national product, right? This is economic development. And this is STD prevalence, very high, 60%, just after the World War II ended. So they started looking at how do we build a socio-ecological intervention. One was integrating deworming, but with other things, which are tackling education, linked to family planning and nutritional programs, community-based health promotion. And then the program was also collaborative and multi-sectorial. It was led by private sector, local governments, and the Japanese government, and they also had a school health law, and as soon as they started doing that, STH began to decline, and it began to decline even before GDP increased. This is showing the power of bringing in a socio-ecological intervention, which is tackling both the social determinants as well as the biomedical determinants. But those are at the national level. You can build those kinds of partnerships. But the other thing we can also need to do, and which is always neglected, are the communities themselves. And in Tanzania, we have the Social Services Committee, SSC, okay? And these are defunct. This was developed during the socialist era in Tanzania. So every village has got that, but they don't have funds to make them work. So we brought in a social enterprise. Here there was poultry farming, and we taught the villagers how to grow chicken, eggs and things. And then we provided help for marketing. So they have a social enterprise. The proceeds were used to, to enhance, the SSC, the working of the SSC, including payment for the members and also payment for the health workers. So I'm not going to go into the details of that. We just went and enhanced it using a social enterprise. Just look at the intervention area where we had the social enterprise, where we had this enhanced local governance. Schisto before we brought in the enhancement was 11.4%. After the enhancement, it dropped to 7%. In the control area, it was more or less, steady. And that was a significant decrease that we managed to do. This is showing that we can engage with the local communities. They can organize the control programs much better than state-led Ministry of Health, kind of programs. And the last thing here, and this is work done here in USF, was looking at community-based vector control using vegetation slashing to let the flies breed in those kind of vegetation. If you get rid of those vegetations, look at what happens, the biting rate just collapses, right? And this is showing the impact it will do. If you bring in slash and clear before the peak biting season, what happens to biting rate? During the peak biting season, look at what happens. And then monthly, you can just destroy the fly populations, and that lingers for a long period of time, and that can have an impact on both MF prevalence, infection prevalence in the human population, and also destroy the annual transmission potential. Once again, this can be organized, and this is wanted by the villagers. So we're giving agency to the villagers to intervene. And then last, I will just end with another way of intervening, of designing intervention programs. And this is in Haiti. And we all know Haiti is under dire development constraints, and we built a DEC salt. This is a drug that is used to control lymphatic filariasis, but you can put it into edible salt, right? So we built a DEC enterprise, social enterprise. So this was selling DEC fortified salt, and we can bring in the financial analysis and say, when will the system break even? Initially, there was a lot of loss, but as the market developed, we were predicting you'll make profits in the year 2027. We modeled the impact of delivering this DEC salt through marketable salt. And this is the MDA program, the public health, the public sector driven anti-A programs. This is when the programs will reach elimination. It'll take about 5 years once you reach 1 year. And this is once if you bring in the salt, the edible salt, because people are eating salt every day. Whereas this MDA programs are annual. Annual programs will take a long period of time. There's problems with coverage as well. Whereas edible salt, you can reach elimination after you reach 1% within a year. So it's a very powerful way of actually intervening. And this is showing that if you look at the cost, this is the total cost of developing the DEC salt intervention. This is a private enterprise, right? Over time, the net cost, this is, the profits minus the cost of production will decrease until it becomes zero when you become break even. But look at the total cost of MDA, that will remain very high. At this point, you're actually recovered, and beyond this point, you're making profits. So this is telling you that there are other ways of intervening, and we need to really look at this whole intervention program going forward. We really want to bring about sustainable parasite control in the developing world. Thanks. Jesse, I'm done.
Thank you so much, Dr. Michael, for that wonderful presentation, and Dr. Sall for your excellent presentation as well. We're going to move forward with some of the questions from our participants, and I'm going to go ahead. Since Dr. Michael, you are still on, I was just wondering whether you could tell us a little bit more about the thresholds that were developed. And some of our participants have a question whether the endemic state is the same as the biting threshold rate, or is the biting rate something that you can calculate, or is it theoretical?
The biting rate, is model derived, because this is a dynamical system, but we have okay, so it is a little bit complicated. I didn't want to go into the details of it. Can I put back the slide just to show people?
Sure.
Okay, is it showing now?
Yes.
Okay, so this is so if you go into the vector biting, any vector-borne disease, right? So the emergence of the disease will depend on the vector abundance, in other words, the biting rate, how much vectors are in the system, and how much infection is there in the system as well, human infection. Let's say people migrating into the place or whatever. Now, below a particular biting rate, which is shown by this blue line, even if you have a lot of infection in the community, infection cannot emerge because there's not enough mosquitoes to transmit, to bite from one person and transmit the parasite to another person. But at a particular point, which is when this thing emerged, at a particular, and this is, we call that as the threshold biting rate, the system will suddenly emerge. And the system can occur in two states, which is the endemic state. This is the prevalence. This is the solid line, or it can still be zero, and that is divided by how much infection there is. This is the prevalence of infection, So these are theoretical constructs, but have we tested this? Yes, we have. We've gone into Papua New Guinea, and I didn't show these results here. There we said we worked out what will be the vector biting thresholds, and there we brought in bed nets, insecticide bed nets, and we made a prediction that in those areas, given the biting threshold and given the decline in the biting rate, some villages we said you're broken transmission coming from the models. So Professor Jim Kazura from Case Western, he actually went back and looked at the places where we were predicting that you're broken transmission on the basis that we have reduced the vector biting rate due to bed nets. We have now gone below the vector biting threshold. We said at this point, there should be zero infection. So they went and tested, they caught mosquitoes, they looked at larvae in the mosquito transmission. All the mosquitoes there where we said we got a high probability of elimination from the models, we saw no infection at all. So there is field, support for this kind of theoretical results as well.
Thank you, Dr. Michael. Dr. SALL, the next question is directed to you. So you talked a lot about towards the end about rapid diagnostics and how they were your model of using it as a social enterprise. So could you tell us a little bit whether those RDTs have been reproduced in other countries, whether this model that you used in Senegal has been translated in other African countries as well? Or you are moving towards it?
Yeah, thank you very much. This model has been actually shown, and in Ghana, I think we know that there are some company that is doing that. And in actually Cote d'Ivoire, we know that there is also that initiative where people are really focusing on developing RDTs and making it available to improve and promote access. One of the ideas we're having with our own program is actually expanding the capacities here so we can provide more raw material to other countries, so we can develop that in other places. So that's what we are working on right now with FIND and other partners.
So basically this is creating it's creating employment for people, at the same time is trying to find a solution to diagnose rapidly and be able to control the disease.
Yeah, actually, what is very important to know is that user diagnostic is most of the time the point of entry to the health system. Mm-hmm. And usually the missing link is really those diagnostic tools, and having a tool that is easy to use and not shipping samples. So that's why we really focus on making sure that that useful product of health is also making sure that to make it sustainable and help actually the disease to be controlled, creating job and wealth where people will invest time to make sure that they can, while developing their own job, expanding also the capacity to manufacture locally the product to protect themselves and control the diseases that are harming them.
So you have training in each of these places to be able to then build capacity to sustain the program. So quickly, I think Dr. Michael also has a question for you, but so Dr. Michael, do you want to ask your question, and then
I just wanted to say, the power of the social enterprises, right? And I'm talking about Haiti as well, Dr. SALL, and this is a very poor country. And so the DEC salt plant, which was built there, is a complete, a private enterprise. and they employ people, and they are developing, expertise within country. They employ people, but look at the other things. They're selling the salt and making it profitable. You're training a whole, new workforce, which is, learning a lot about management and all kinds of things. But look at what happened during COVID, right? The public health system just went dysfunctional in Haiti, completely stopped.
And the earthquake.
And the earthquake, and then the political assassination and things like that.
And the hurricane.
Hurricane, is completely stopped. No delivery of drugs, for about 2 years. But they were still selling the salt. And this is, so we need to start thinking also, how do we, is, parasite control a public, through only the public sector, or what is the role of the private sector to come in and maybe play a role? Because what I find working with the private sector people, for them, the bottom line is important, profit, right? They have to make it work. And they will find ways of making it work, which is not the case. It's very difficult for the public sector to do the same because they are rule book driven. They can't be very flexible because everything is controlled and regulated. Whereas the private sector are much more nimble. So we need to find new ways of governance as well. How do we bring in this kind of approaches? And Africa is a really good example. There's a lot of entrepreneurship, on the ground. So this is an open-ended question. So we need to break out from this old idea that only the public health sector can implement control programs. And how do we bring in other partners as well?
Thank you, Dr. Michael. And I don't know, Dr. SALL, if you want to respond to that, along with what I was hoping is that, given that you have shown some models, both of you, in terms of successful models that have used a social enterprise as well as social development, you talked about the Japan model as well as your work in Tanzania, Dr. Michael, and then Dr. SALL, you were talking about the rapid diagnostic programs. Are there ways in which that you have evaluated these programs further to be able to show that they are successful and they are working with outcomes where you are not only improving the living conditions for people as well as controlling the disease?
Dr. SALL, do you want to go first?
Yeah, no problem. We are actually doing that in two ways. Number one is we have built up some work where we bring diagnostic into the community, where it's not just making the diagnostic that make actually the people improve their economic status, but also by delivering some healthcare community workers are actually trained, and they, within their community, help people that have fevers and that have some syndrome to be able to get the test and know the status and take action into going to the health system or having some care being provided. So it's going two ways. And by setting up this experiment, we saw very clearly that we can have an impact really socially that is critically important, but also on the disease as well. So that's why one of our major work right now is to say, okay, we need to do three different things. Number one is to find different use case on different disease where we can apply this sort of approach. And number two, try to improve and augment the capacity here to train people and also to manufacture some raw materials so we can support some other people in other countries to do that. So I think we would see some major effect when we see these amplifications, not only from one example, one country, one community, but when this is largely happening, as it is happening right now for COVID, for instance. It's really something that will have major impact.
To translate this further.
Yeah.
Sure.
But also, I think this goes back to policy as well, right? So right. The Japanese example is at the highest political level. They made those policy decisions that we have to integrate, bring in the multi-sectors. We have to have the biomedical tool, but within social development. Mm-hmm. So we have to integrate, and that is a fantastic example that the rest of, I grew up in Malaysia, right? And at that time, when I was growing up, I saw one of my, colleague, classmates, he had ascaris, the roundworm, coming out of him, and which freaked the hell out of us, and that was like in the 70s. Now, if you go back to Malaysia and talk about worm infection, they'll laugh at you, because economic development has occurred, water and sanitation, and that has got rid of infections, and so I think we need to, and this is a conversation we need to have, Dr. SALL, as well. How do we also bring in the government speaking? We had this workshop once in Tanzania, and we brought the government, we brought the social, the private sector, and then we brought the NGOs. How do we started, and that's where the community, the example I gave you of Tanzania came about. How do we bring all the sectors together? And we said, how do we bring in sustainable funding? See, that work was funded by Gates, who were looking at sustaining the control programs and bringing in the community to have a say. And so we found this kind of local bodies were there, but they were defunct. So how do we bring it? And the government couldn't support those kind of bodies, local bodies. So we brought in the entrepreneurs to help us to build the social enterprise, the business models, and then we brought the universities to teach the villagers how to grow chicken, for marketing purposes, and eggs and things like that. So that was an example of how we brought in people. We also had health ministry people in the meeting who gave us the go ahead, because they were the guarantors to the bank as well, for releasing money. So I think this is also about policy, and not just social enterprise, which is, ad hoc here and there, but at the highest policy levels, we need to bring about this change.
Thank you so much, Dr. Michael and Dr. SALL. We are at the end of our time, and please feel free to go ahead, and if you have any further questions, reach out to us, and we can have Dr. SALL and Dr. Michael answer those after this meeting. So with that, I wanted to thank each of our speakers for those outstanding presentations, and for us to be able to think further about this topic and to reframe the way we understand NTD control. And just the thought of whether we want to even rename it to neglected infectious diseases, because in trying to geographically limit it to tropical infectious diseases, we tend to forget that it impacts so many different countries, and it's not just a problem of the South always. And it also, because of which the funding has always been an issue. So these are some things to ponder over, and also as we continue to think about this topic in terms of incorporating social development and integrating it with our biomedical approaches, we will be discussing this further in the spring and bringing in another panel. So I appreciate all of your thoughts on this, and I hope you all have a lovely day and a lovely afternoon and evening. Thank you again, Dr. SALL and Dr. Michael.
Thank you.
Thank you, Lynette. Great pleasure for having you. Thanks.